we're going to talk about chest trauma. You need to make sure that you read the correlating books pages in your book, as with all PowerPoints. Okay, so let's just do a short review of the anatomy of the chest. Okay, you guys know that you have two lungs, a right and a left. This also shows the heart and then the diaphragm, which helps us with inspiration and expiration, with breathing. Anatomy of the chest, we have the pleural space, and the pleural space is just the space between the lung and the chest wall. So you want to make sure that you know that area. This is just a picture that just shows the anatomy of the chest, and just to remind you, I want you to know that during the semester and as we go over things, you have to know the anatomy of the chest, of the lungs, of the heart, the vascular system. If you do not remember the anatomy from A&P, then you need to go back on your own, make sure that you review it. Because if you do not understand the anatomy, there is no way you're going to understand the disease process, and you're going to be lost. So make that your baseline foundation. If you need a quick review, that's fine. Go back and look, but make sure you understand the anatomy so that you can understand the disease processes that we're going to look at more in depth this semester. Alright, main causes of chest trauma. First one, blunt trauma. That's just a blunt force to the chest that causes a sudden compression. The second one, penetrating trauma. That's whenever we have a projectile that enters the chest wall, which causes a hole. That hole can be small or it can be large. It's just any foreign object that penetrates the chest wall. Statistics, again, I don't care that you guys memorize numbers, statistics, dates, years. If I want you to know that, I would tell you. But just to put this in perspective, there is approximately 16,000 deaths per year that's attributed to chest trauma. So that's a pretty good number, so we want to look at that. So question, from blunt trauma or penetrating trauma, which one do you believe is more common? So push pause on your PowerPoint for just a second and think about it, which one you believe is more common, and think about why you believe it's more common, and then go ahead and resume, and let's go on to the next slide and find out. We want, during this semester and throughout the PowerPoints this semester, we want you to start thinking deeper and understanding why things occur the way that they do. So, were you right? Did you think that blunt trauma is the most common, that it occurs more than penetrating trauma? And if you were right, let's move on to the next slide and see if your thoughts as to why were some of these on the next slide. What is the most common cause of chest trauma? Car accidents, and that's due to the steering wheel, and hopefully you have a seatbelt on, so that can cause it as well. Falls and the handlebars from bike wrecks are a big one. So were some of those the things that went through your mind? Chest injuries can be life-threatening, and most often they are, and they can result in things such as hypoxemia, and we know that hypoxemia is just the disruption of the airway or injury to the lung. It causes problems with our gas exchange, and if we don't have gas exchange, we can't oxygenate our body or the tissues. All right. It can cause hypovolemia, and hypovolemia we know is blood loss. It can also cause cardiac failure or tamponade. And what tamponade is, it's just the blood that's accumulating around the heart, in the sac of the heart. And we will talk more about tamponade this semester. So with blunt trauma, we tend to have sternal and rib fractures. Rib fractures being the most common thing with chest trauma. Sternal fractures are usually from the steering wheel. Again, I believe that I've already stated that, but that's the most common thing that will cause a sternal fracture. But with these fractures, why would they cause things such as atelectasis, pneumonitis, or hypoxemia? Well, we talked about the hypoxemia a little bit. Obviously, if we have broken ribs, we're not going to breathe as deeply as we normally would. And if we're not breathing deep and opening up those airways, we can't get gas exchange in, so we could have hypoxemia. If we're not breathing deep and getting that oxygen down in there, then we could have the atelectasis occur. and then the inflammation that would occur from the trauma to our body causing the pneumonitis. Priority of care for a simple rib fracture, if we just have someone who we're taking care of who has a rib fracture, is pain management. Now obviously we've got to make sure that they're able to breathe and we don't have anything penetrating into the lung, but then that wouldn't be classified as a simple rib fracture. So pain management with these patients, and we would need to teach them to splint, because by splinting it can help reduce the discomfort that our patient is having. This is a picture of a flail chest. And what exactly is a flail chest? Well, a flail chest is the breaking of 3 or more ribs in 2 or more places, and it results in what we call a free-floating rib. You can see there on the picture, it shows you where the same rib is broken in 2 separate places there. Alright, when this happens, we lose stability, and it usually causes respiratory impairment and usually severe respiratory distress. Okay. Alright, so signs and symptoms of a flail chest. What are we going to see if our patient comes into us with a flail chest? We're going to see shortness of breath, and you can understand that, right? We have injury to our chest, so we're not going to be able to breathe as well as we would like. We're going to see what we call paradoxical movement, and there's a link on your screen there, and if you click on that, you'll actually be able to see what a patient looks like who has a flail chest, and I do recommend that you see it. It puts it in better perspective so that you understand what's going on. But as far as what I actually mean by paradoxical movement, it means that normally sitting here, as we breathe in, our chest will expand, and then when we breathe out, then our chest kind of collapses down a little bit and allows that air to go out. With paradoxical movement, it means that it's being pulled inward during inspiration, which will reduce the amount of air that can be pulled into our lungs. So instead of when I breathe in, my chest going out, when I breathe in, my chest actually collapses. It goes in that area there. And then on the same token, whenever I breathe out, instead of the air, my chest going in and pushing that air out, well, it actually bulges on expiration and it won't allow the air to escape. So it's just the opposite of what would occur during normal inspiration and expiration, and hopefully you can understand how that would affect my breathing and how that could put me into respiratory distress. Bruising and swelling, and that's just with any trauma that we have. You're going to see bruising and swelling. A flail chest is an emergency, and we want to make sure that we get proper care for them, because they're not going to be able to get the oxygen that they need. And let me back up just a second and tell you that you may also see crepitus. And what is crepitus? It's just the grinding of the bone ends. Okay, you may have heard people even in your family say, I have crepitus. Maybe they say they have it in their knee. It sounds like a little popping sound in there, all right, or feels like a little popping in there whenever they move around. Penetrating trauma. Most often, if we have a penetrating chest trauma, we're going to see a pneumothorax or possibly cardiac tamponade. Now, please don't think that you only see pneumothorax and cardiac tamponade with penetrating trauma, but if you have a patient who has penetrating chest trauma, these are the 2 things that you will see. But these things can also occur under other circumstances. Alright, so there are 3 types of pneumothoraxes, or pneumos is what I will call them, that we're going to talk about. Number 1, simple. Number 2, traumatic. Number 3, tension. Usually with a simple or a closed pneumothorax, there's an opening in the lung tissue, and that leaks air into our chest cavity. That's what occurs. There's a picture on your slide there that kind of shows what a pneumothorax looks like. You can see the lung tissue and the pleural space there between the lung and the chest wall. See how large that is? It'll be on the patient's right side, but when you're looking at the picture, it's on the left there. It can be caused by blunt trauma. It can be spontaneous, and normally it's self-correcting. We don't have to do a whole lot for it. It's just a simple, small, closed pneumothorax, and our body usually corrects that. And again, it's usually caused by a bleb or trauma. And it's normally a bleb in an otherwise healthy person. So if there's been no trauma or nothing's really going on with the patient and we have a small pneumothorax, then it's usually caused from a bleb. And a bleb is just an area on the lung that actually blows out or opens up and allows air to escape, and of course that changes the pressure in the cavity there, so it will decrease that portion of the lung and open up that pleural space just a little bit. Okay, so symptoms of a pneumothorax, what are we going to see? Sudden sharp chest pain, shortness of breath, rapid heart rate, rapid respirations. Our breath sounds are going to be diminished or possibly absent on the side that the pneumothorax occurs. Now, when you're studying for this and when you're looking at this, I want you to think why. I want you to ask yourself why. Don't just memorize that this, and this occurs when we have a pneumothorax. Understand why our heart rate goes up. Understand why we are breathing faster. Okay? Obviously, if I have a collapsed lung, I don't have the exposed air, lung tissue that I once had, so my heart rate's going to go up to compensate. I'm going to breathe faster because I'm trying to get more oxygen in. And if you look at the picture there, you can see how the lung has collapsed, so I'm not going to hear air moving over the open space there. So try to start looking at the disease processes from this perspective and understanding why you're hearing what you're hearing. Okay, so a traumatic or an open pneumothorax, let's talk about that just a second. What this actually is, there's a picture there on your screen that kind of shows you. It's kind of a gory picture, but that's what it is. It's an opening in the chest cavity that allows air to enter into your pleural space. Alright, it causes the lung to collapse, which is due to the increased pressure in the pleural cavity, and it can be life-threatening and deteriorate very fast. So, and you can see from this picture, I think that looks pretty life-threatening. It's usually accompanied by a hemothorax. And what is a hemothorax? Well, pneumothorax, the pneumo means air. Okay, so there's air in the space, and with a hemothorax, well, hemo means blood, so that means there's blood in that space. So usually this traumatic or an open a pneumothorax is accompanied by a hemothorax. Okay, so let's say that we have a gunshot wound. That would be an example of an open pneumothorax, okay? This guy in my slide shoots me in the chest, and a bullet goes into the chest wall. Now, obviously, you're probably going to have a little bit of a hemothorax there as well, but bear with me and let's look at these next slides to understand what happens as we go through this process. Okay, so with an open pneumothorax, this just shows you a picture. The next several slides just shows the picture of what is occurring with an open pneumothorax, okay? This shows that the patient see how whenever they inhale, air does go in to our lungs, but also because we have this open hole in our chest wall, air is allowed to go into the chest cavity. So now you can see that yellow strip there, and there's air in there, and my lung's not as expanded as it should be. Then this shows that as I exhale, I still have that area there, and you can see where the air is free flowing in and out of my chest wall. Now that air that's coming in and out of my chest wall is not actually in my lung where the gas exchange occurs, it's in the pleural space there. And again, this is inhale, and you can see how each time that I breathe in and out that this space is changing in size. And again, we exhale out. And one more picture here, and see how this shows you that the lung is almost nothing. There is so much air and probably blood in that pleural space at this point that that lung is not even functioning. Okay, so what are we going to see? signs and symptoms of the patient with an open pneumothorax. Other than the picture that I showed you earlier, your big hole in the chest wall, if it was like that. They're going to have dyspnea meaning just shortness of breath, and hopefully you can understand that. Sudden sharp pain, they're going to have all kinds of pain if they have a huge gunshot or open wound like that. Cutaneous emphysema, and I'll talk to you a little bit more about subcutaneous emphysema in just a little bit. We call that sub-Q air. That's the same thing, it's just a different term, and that's what you'll hear it referred to at the hospital. Decreased lung sounds on the affected side, and you're going to hear that in both pneumothorax, and I explained those in previous slides as to why you wouldn't hear it. If there's no lung tissue there, then you're not going to hear the air going in and out. You're not going to hear any movement. Also, with an open pneumothorax, you're going to see, or possibly see, red bubbles on exhalation from the wound. So if you have this big open hole in someone's chest, it's a good possibility that you're going to see like this bubbling coming out of their chest with expiration. It's known as a sucking chest wound. Okay, so this is a picture of what a sucking chest wound is, and you can see on the pictures how, as the air, as we're breathing out, how the air will come from the outside into the chest cavity, and then whenever we breathe in, how that air will escape out. It pushes that out. That's why you'll see that red bubbling coming out of that chest wound. All right, and again, the air that we breathe through our mouth and into our lungs, that's not what is filling that cavity up. Okay, there is an actual external hole to the outside world, and it's allowing air to just free flow. It goes in and out of our chest wall. That is not the air that we use for oxygenation. I promised you that I'd talk to you about subcutaneous emphysema, or sub-Q air, which is what we will hear it called about at the hospital. This is when air collects in your subcutaneous tissue or your fat tissue from the pressure in the pleural cavity. Whenever you have a patient who has subcutaneous tissue, and I'm sure that we will experience this semester, it feels kind of like bubble wrap or Rice Krispies underneath the skin, and it can be seen from your waist or your groin area up. Alright, this picture on your slide shows the patient. The picture on the right is without the sub-Q air. The picture on the left is with the sub-Q air, and you can tell the big difference in the patient. This is the same patient. One he has sub-Q air and one he doesn't. And there's no longer room in that cavity and into the sub-Q tissue. So when you push on their chest area, you can feel like this, what it feels like underneath there. If you take a stethoscope chest to listen to their heart and lungs, you're going to hear students into the room as possible so that everyone has that opportunity. This is just a picture of an occlusive chest wound dressing. If you did have a chest wound or an open wound like this, the best thing that we do is place a chest drain, and of course an occlusive dressing over that. But a chest drain is what we really want. But is before we would place a chest drain, or say you're out and you don't have anything, then they tell you to put an occlusive dressing over the side, and this picture actually shows, see how it's taped on 3 sides. One side is left open, and in theory, what this should do is prevent the air from entering the space whenever we breathe in, but then it would allow air to escape through that one side that isn't taped down. So in theory, this is supposed to work. I don't know that research shows that it is perfect. Again, the one thing we want to do is get a chest drain placed in. That's the most important situation. But if you're out and this is all the supplies you have, this is what you would want to do. Okay, so let's talk a little bit about tension pneumothorax. Tension pneumothorax is whenever air builds up in that pleural space and there's nowhere for the air to escape. So air is getting into the pleural space, but it can't get out. Alright, it usually results in the collapse of lung on the affected side because of the pressure on the mediastinum, the other lung, and the greater vessels. And as you can imagine, this would shift your heart over to the side. I'm going to show you a picture here in just a minute of what this might look like. This could be from a lacerated lung, or a small opening, or even a wound in our chest wall. This is a picture of what a tension pneumothorax may look like. Each time we inhale, the lung will collapse just a little bit further, but the difference in the tension pneumothorax is that with the other one, you know, the air had a place to kind of shift to or go out of if it was an open wound in the body. In this type of pneumothorax, that air is trapped. So the air is getting into the pleural space, but there's no free flow in and out. There's no place for that air to escape. This picture just shows you how the pleural space is getting more and more air in it. The lung is collapsing more and more, and there's no air that's able to get out of that space. I told you that the greater vessels in the heart would be pushed over, and this is just a picture of that, where it's showing that the trachea is pushed over to the good side, the lung that isn't collapsed, and that the heart's being compressed. Alright, so what are we going to do if this occurs to us? What are we going to do to get that air out of that space that it just keeps building up in there? Well, we're going to do a needle decompression. And you can see on here the picture, it shows where they're going in the second intercostal space there. And they're actually just going to stick this needle in, and that allows that air to escape out of there. Another thing that you may see done is chest tube placement, and I think that's pretty common. The needle decompression is done in a more severe, got to get it done at this exact moment, they're going to die type situation. So you'll probably see chest tubes placed for this. I've already taught you briefly about a hemothorax. That's just whenever your pleural space fills with blood. It usually occurs because of a lacerated blood vessel in the thorax region. As the blood increases, it puts pressure on your heart and the other vessels in the chest cavity. And the next few slides is going to show you the progression of that and how that occurs. Okay, so this is just your demonstration in your picture, and again, this is going to look like some of the previous pictures, but you can see the red line there, and that is the air that's accumulating in the pleural space. And we'll go on to the next picture and see how it has gotten larger. And again, this is just blood that is accumulating. That's what a hemothorax is. And larger, and it will continue to get larger. And again, it's larger, and almost to where the lung space is nothing. Once it gets to this point, your lung is completely collapsed, and it could put pressure on your heart. Okay, so we have to get that drained out of there. Now with a hemothorax, where does that blood come from? Okay, why is that blood even in there? Well, it comes from the blood vessels that are in there. We're very vascular, have all of those blood vessels. I will tell you another thing that could cause that, maybe a tumor, if your patient has a tumor. So those are two things that could cause that. Not the only thing, but the two things that could allow that blood to get in there. And this just shows you a picture. What is our goal of treatment with this? Well, we have to get that blood out of there. Our goal or treatment with any type of pneumothorax, hemothorax or pneumothorax, we have to get the air or the blood from the pleural space. And this picture shows you, the one on the left shows you that the chest tube has been inserted into the chest wall. It's into that cavity, and it allows the lung to re-expand. And once that lung has re-expanded, then we'll go ahead and take that chest tube out. So that's what you'll usually see in these types of situations. We will talk about chest tubes a little bit later in one of your labs, and you guys will actually get to see what a chest tube looks like. And in clinical, hopefully you will see chest tubes, and we'll talk about them as your patients have them. Last but certainly not least, I promised you we'd talk about tamponade a little bit more. So this is a picture of the heart and the pericardial sac that's around it, and kind of a stick figure here. This is pericardial tamponade. What is that? Well, that's whenever blood or fluid leak into the pericardial sac, and that pericardial sac's what surrounds our heart. As that sac fills, it causes it to expand until it can't expand anymore. So it will expand out, but eventually it gets to a point that it can't. Once that pericardial sac can't expand anymore, then that fluid or the blood starts to put pressure on the heart. Okay, so now your heart can't fully expand, and if your heart can't expand, it can't pump effectively. If your heart can't pump, then what's going to happen? All right, your blood pressure is going to drop, your heart rates starts to increase to be able to compensate, but it's unable. The patient's level of consciousness is going to drop, and eventually the patient's going to go into cardiac arrest. So what you need to know about tamponade is this. It's the sac around the heart. It fills up with fluid or blood. That sac can expand some, and it will, to the point that it can't expand anymore. At that point, if more fluid gets in there, then it's going to start pushing on the heart. Well, your heart beats and it pumps, and if fluid is pushing on that, pressure on it does not allow your heart to beat and pump, then it can't pump out the blood to the rest of your body, and it's going to put us into cardiac arrest. The treatment for this is what we call a pericardial window, and that's a surgery, and it's where they go in and cut into the pericardial sac there and get that fluid out of there, and so that our heart can pump efficiently again. So when you're thinking about this, I don't want you to memorize that your heart rate goes up and your blood pressure starts. I don't want you to memorize what is happening. I want you to understand why that's happening. Okay, so initially whenever that's happening, and the fluid is pushing on our heart rate it starts to jump up because it can't pump the way it normally does. So it's going to increase our heart rate to pump faster to try to push out the blood that we need. But as that fluid closes in, it's going to drop our heart rate because it's stopping our heart. So you need to understand how that procedure works. Yes, it will initially increase our heart rate to the point that it can't do it anymore, and then it starts to go down. And of course that's going to affect our blood pressure. If our heart can't pump out the blood, then we have no pressure there. So I want you to understand how that disease process works. And that is it for chest trauma.